So good afternoon, everyone. Welcome to this year's 2021 Matrix and GP Track Summit, featuring disruptive technologies and innovations. During this poster session, we'll have 3 posters presented outlining projects in telehealth that will give insight into innovations and present new ideas to consider. Detailed data gathering and research into each of these areas is what makes undertaking telehealth research beneficial to all of us. We're grateful for our presenters that are willing to share their findings and know that you will come away with a better understanding of telehealth. Each presenter will be given up to 10 minutes to introduce themselves and explain their poster, and the remaining 4 minutes will be left for questions and comments. If you prefer, you may also use the chat feature on your screen to ask questions. We have found in past sessions, so I'll let you know up front, it's a lot faster if you just open up, when we open up for questions, if you open up your microphone in order to save some time. If some of the posters run a little bit short, we have a couple extra minutes at the end, we can answer questions from all 3 presenters. We want to make sure that our presenters are allowed time to present, and so that we're going to stay firmly with that 14-minute time frame. We want to thank all our poster presenters and our audience for joining us today. Also, we strongly encourage everyone to go vote for the People's Choice poster presentation in the Summit page. So you go to your main page, underneath the tab posters, you'll see Vote for People's Choice poster. So if you have any further questions or would like to continue any discussion with our presenters, feel free to connect with them at the Summit. To do so, you can review the Attendees tab on the main page of the Summit, and then message them to connect at networking tables in the exhibitor space, or you can email them. All righty, with that, we'll go on to our first poster being presented by Dan and Stephanie. If you all want to go ahead and start.
Thanks so much, Tim, for the introduction and the opportunity to present through poster our 3 pretty innovative models that we chose to highlight. So my name is Dan Kebzu. I'm the Senior Director of Business Development. I am with Array Behavioral Care. It is somewhat of a newer name. You may know us of Insight Telepsychiatry, or more recently as Insight Plus Regroup. We had a merger last year, and this is probably one of the first times we've had an opportunity to present and exhibit under the new brand, Array Behavioral Care. While the brand is new, we are not new to this space. So we've actually been using telebehavioral health and telepsychiatry since 1999. So one of the pioneers in the space, early adopters, based in the Mid-Atlantic region in Mount Laurel, right outside Philadelphia, and have been using it in various capacities since kind of the early days of telehealth, when technology and pretty much everything was pretty primitive. So excited to see so much growth in the industry, some regulations that we've been lobbying and fighting for really come down. Really the only silver lining of COVID, I feel like, has been around telehealth and some of the regulations coming down. So some of that has really enabled some of these models to be more effective and give us more options. So that's who we are as an organization. We're a telebehavioral health provider. We have over 500 behavioral health clinicians on as part of our clinical staff. It is a national operation. We've got programs in 37 states and really touch pretty much every state in the Mid-Atlantic region. And as I shared, I mean, that's really who we are and where we got our start. We do this on quite a large scale, just to give you a sense that we did about 350,000 telebehavioral health encounters just last year, just to give you a sense of kind of the volumes that we're seeing. So in this poster, and just kind of switching down to the 3 models that I have highlighted here, we chose kind of different twists or variations on some of our more traditional offerings. Historically, looking at the on-demand model first, we've typically offered psychiatry or nurse practitioners in an on-demand capacity. So essentially working with hospitals, inpatient units, medical surgical floors, or even correctional facilities to provide on-demand psychiatric access to fill any gaps that organizations might have with on-site care. We've done this for about really since the early days of the work we've done. more recently have found that some organizations would also benefit of having a LCSW or non-prescribing clinician being able to also provide that emergency access to hospitals or inpatient units. So we designed this model with kind of the same framework and infrastructure that we use for on-demand psychiatry, just using non-prescribing clinicians like LCSWs. This is particularly relevant in states where you can have LCSWs make calls on level of care determinations and actually do commitments. In some states, it's still mandated that a physician needs to play a role in that process. And at least part of this may not be as relevant to those types of programs as it would be to states like maybe North Carolina or Virginia or other states that can focus on just, again, non-prescribing clinicians. So essentially with this model, we're able to set up on-demand access to LCSWs, either around the clock, 24/7, or customized coverage periods like nights and weekends. So essentially organizations can call in once a psychiatric patient presents in the emergency department on the med floors. Our remote behavioral health clinicians can then beam in or then also work with on-site staff remotely to help triage patients. We're also able to do assessments via video link. Typically, we're fairly agnostic in terms of platforms that we use. So it could take the form of maybe a video platform, like software platform, or maybe some video hardware that they were using. So we're able to remotely, either telephonically or through video, do triage assessment, but also then help on the back end of that on the case management piece. So oftentimes the evaluation is just kind of half of what they need. Sometimes a big part of the challenge becomes kind of finding that bed or other place for a referral. And these LCSWs and other folks can really beam in and really make those calls out to local community resources and to inpatient units and try to get them placed. Just helping hospitals reduce length of stay, help folks get the care that they need faster, and just kind of unclog a lot of the system around boarding that so many hospitals across the country really encounter. So again, it's a little bit of a different twist to our historical kind of on-demand model using prescribers, but we have found a lot of interest in some of our local partners for it. And we've also been reaching out to some of our other partners who who may be able to kind of utilize at least the case management piece of this to help move folks along and get them the care that they need. So moving on to the second model that we have highlighted here in the middle, which is virtual collaborative care. This model utilizes our scheduled care model, where essentially we can dedicate clinicians to work on an ongoing basis with primary care, FQHCs, kind of that PCP type space. There's different flavors to this, and I can highlight kind of broadly what they are, but happy to go into a little bit more detail in the Q&A or as a follow-up. But the model that we have presented here is more kind of that collaborative piece, which is kind of a modification of the AIMS model, where we have integrated both an LCSW or behavioral health case manager, as well as a consulting psychiatrist. So in this model, the LCSW or case manager works more directly with the patient, the PCP, and the consulting psychiatrist really is just doing case review, and then also acts in the capacity as a resource to the primary care provider. Rarely, if ever, kind of seeing the patient with the way that this is laid out. So again, there's different flavors to this. We've also helped design and set up programs where the psychiatrist is really just kind of managing a caseload. So it's kind of a co-located model where the psychiatrist has referred patients from on-site behavioral health folks and then either continues to manage that caseload, or then maybe there's a warm handoff back and forth to the PCP, just maybe doing a treatment plan. And then if there's any more acute needs, then there's maybe a handoff back and forth until they're stable and can be managed by the PCP. So there's different flavors to this, but we've seen an increasing need and demand for mental health services within primary care. I mean, with COVID and all the trauma and stress related to it, I mean, so many primary care practices have had to provide mental health services, and not all primary care folks are trained or feel like they have the expertise to provide those services. So having that kind of remote specialist be able to beam in virtually, I mean, is a big benefit to a lot of our partners and programs across the country. The third model that we highlighted here, and Tim, rein me in if I'm going over on time. I don't have the clock up, but I'll try to cover this one fairly quickly.
You're up to 7 minutes.
All right, I'm still good then. So this clinic and in-home kind of hybrid model, it's a little bit of a different twist to our traditional scheduled model in that historically we've aligned either psychiatry, nurse practitioners, or LCSWs to work on an ongoing basis with the facilities. So 2 days a week, our remote provider becomes their provider, and they do traditional things like assessments, medication management. If the technology allows, we participate remotely in treatment teams, do case reviews, and really not too limited in terms of how we can work with patients, and then also the on-site clinicians that we're working directly with. With COVID and really overnight, so many of our partners in outpatient clinics have had to design in-home models because they've had to shutter their doors. They've had to really remove services in the home to stay connected to patients, and just didn't have a lot of options. So at least at first, it was kind of on the fly kind of adjustments we had to make to really make this work. We did have the advantage that we have an in-home model already, so we were able to kind of fall back on some of those best practices that we're able to wrap into those programs and share with them, just about how you set up locations, how you do patient education, just making sure the space that they're in the home is secure, it's private, it meets the same kind of security and privacy standards as you would have, as it would have within the clinic. So with that same theme in mind, I mean, we're still able with that in-home model to connect remotely to electronic health records, do e-prescribing remotely, and connect patients directly with pharmacies if they need medications. And then also even do or help the partners that we have do kind of remote education about telehealth, what is it, best practices, and all that, and everything really that goes with these sessions. So it's a little bit of a hybrid. It's essentially using our scheduled care model and really giving consumers an option of whether they get services within a clinic or even have an option of kind of follow-ups within the home now that clinics have been really opening their doors again. Now that I don't want to say we're out of the woods yet with COVID, because I think there's still some of that impact that we're being felt. But largely because of that, we had to move to this model with our scheduled care model. And luckily, with the regulations coming down and reimbursement now being available to folks being in their home, it's allowed us more options as well as our partners to provide care. I will mention that we do have an in-home model, as I alluded to before. So that's more of kind of a referral link that we have partnerships with insurance companies and primary care, where essentially they can just refer over to a virtual practice. So that's a little bit different than what I highlighted here. This is more kind of a direct partnership that we have with community mental health centers and FQHCs, where we're working remotely with patients that they're owning and managing. And I think that's it. I'm going to pause there. And Tim, I don't know if we're doing questions now or wait until the end.
Yeah, we'll do questions now.
Okay. Well, thank you so much for the opportunity again to share our three operational models.
Dan? Hi, this is Nina. I'm not sure, Tim, if we're doing it through chat or live in terms of Q&A.
You can go on and do live. That is to save time.
Okay. Yeah. So Dan, thank you so much. You know, I think all of us know the tremendous, overwhelming need for, psychological services. So my question has to do with student health, and especially with COVID-19. And I know that Teladoc and some of the even Aetna has signed up for Teladoc, that it's been an incredible service. And I would hate to see that go away for our student population, because they find it very attractive, not having to sit in a room and look at other people that are trying to get services. So I'm just curious, have you interfaced a lot in that realm?
Yeah, it's a great question. And I mean, students, across the country have been impacted largely by COVID-19. Just being home. And as you alluded to, I think they even sometimes have a preference to have this kind of remote session. They just take to the technology and sometimes actually prefer getting services in this way. So yes, we have had the opportunity to help out schools, just give them more capacity, referral options. We rolled out a program at Rutgers where we've been able to integrate some services within a counseling center, and then being kind of an extension of that, and connecting with students in their home. So yeah, we're happy that we've been able to kind of play a role in helping students out throughout all this craziness.
Yeah, thank you.
And a reminder to everyone, if we don't have time for all the questions or comments, you can meet up with the presenters by going to the main page and looking under attendees. Everyone who is attending is. Okay. We only have 1 minute left. We'll go on and we'll add that to the end if there are additional questions on the end, if you will. Want to take that down, Dan, and we'll have Ahmad put his presentation up. Very good.
Perfect. Do you guys see my screen?
Yes, we can.
Excellent.
Go ahead.
Excellent. Hello, everyone. My name is Ahmed. I'm an emergency physician at George Washington University Hospital and also a teleinformatics and digital health fellow. Today, I'm going to talk to you about a survey we've done at GW to figure out what was the effect of COVID-19 and the pandemic on surgeons' interest of using telemedicine and their perception of their patient interest post-surgery. So what we have done, you guys probably know that every time you want to start a new telemedicine venture, it's really hard to figure out where do you start, which specialty do you pick, which niche, which area do you start with. So we picked this specific area specifically for the global surgical period. So global surgical period is whenever a patient has a surgery, there is a global surgical period after that surgery where the surgeon cannot bill the insurance company or bill the patient, because any kind of visit or evaluation that happens during this time is considered part of the surgery itself or part of the procedure. So what we've done is we wanted to see if COVID-19 has changed our surgeons' perspective about using telemedicine. During the time frame between November and January, these 3 months, we targeted our 84 surgeons here at GW in multi-practice, in a multi-specialty kind of practice, where bariatric, breast, colorectal, neurosurgery, cardiothoracic, dermatology, general, interventional, urology, and even transplant and vascular were included in this study. We got around 61% response rate on this survey. Our population were mainly male and older. We had around half of our population was more than 46 or older than 46. And about 2/3 of our population were even more practiced. They had more than 10 years in the practice, specifically at GW. So when we started asking about when we asked our surgeons to tell us more about these visits, half of our surgeons said that at least every week they do 5 of these post-op visits. And 2/3 of these visits were included in the global surgical period, where around 25% of these visits just had a normal examination where they see the patient, they look good, they go home. 25%, the other 25% were like, you know what, you look good, but I want to do some kind of advanced imaging. Let's do a CT scan or something. What we found that was really interesting, and I don't know if this was already because of COVID-19 or not, we found that half of our surgeons were interested in using text messaging for post-op evaluation or getting in touch with their patient. And around 80% of them were preferred or were more interested in using video visits. Of course, just to give you a hint, in this population, post-COVID-19, 98% had at least conducted a televisit before. So now they're more familiar with what is televisits and what is telemedicine. Um, and when specifically we tried to figure out what was the effect, or tried to measure what was the COVID-19 effect on their interest, our surgeons, more than 2/3 of our, actually 3/4 of our surgeons said that they think that the pandemic has increased their interest by about, you know, we ranked them between increased and highly increased. And they thought that it was either increased or highly increased from didn't change. Um, then about 38% had more increased interest in text. But what was really interesting is how they thought their patient were more interested than they are. 94% of their patients were interested in video and 54% were interested in text. As you can see on the graph on the right side, blue is patient and orange is physicians. So it seems like surgeons think that there is a gap. They do think that there is a gap between their patient expectations or their patient interest in telemedicine or in televisits, specifically in this area, versus their own opinion or their own perception and interest. And we think, honestly, that surgeons are a very hard population to get into telemedicine, because most of the time they want to see the patient physically, put their hand on that belly, make sure that things didn't go wild, especially after a surgery. So we think next step would be more of, we need to understand why there is a gap. Maybe surveying patients and ask them about their own interest and what do they like and what exactly they don't like. And probably also run a feasibility study and a trial and figure out how things goes, and take their patient's opinion and physician's opinions as well. Um, and by the end of this, you probably have more minutes than I expected. So please feel free to ask any questions here or later. Thank you.
I just have one question about the text. Actually, I have several questions, but one is the platform. There was a concern here at the University of Louisville as to trying to follow or to standardize a texting platform, because all of our providers may have different different servers or different providers. Some may be AT&T and others Verizon, whatever. And there was not a way to standardize that they could track and keep that and know that every text that had to do with PHI was secure and encrypted. So the rule of thumb is we do not do texting because we just can't keep a track on the security of it. How did you track that on your security?
So in our program in GW, when we actually implemented text, we did not mean text messaging through a cellular surface. We did it through our portal. So our physicians had like a direct connection line in Cerner with and in TouchWork, with our patients, where they send them a message and then the patient basically just logging into the portal and reply to that message. And sometimes we ask them to send us a picture of something specific and they reply back. And we do have guidelines. For example, if they didn't reply within that time frame, then we step it up to the next step, where we either give them a call or arrange them for a follow-up, like either a video follow-up or in-person follow-up.
Okay, so it's the patient portal. When you're talking about text,
Yes.
You're talking about within the patient portal and the EHR. Okay, very good.
Yeah.
We do have a question here. Did the survey capture physician lower interest in video and text? They were concerned about this capture of imaging or some other limitation related to potential risk from an inpatient visit.
Yeah, so if I understood this question right, was it Was it that they wanted to get the patient back to the hospital versus getting imaging? Is that right?
I don't know, Ed, can you maybe clarify? We got a few minutes. You can open your mic if you'd like. Anything related to an inpatient visit, imaging, seeing the patient live, their wound, etc.
Yeah, so that's I think where we think the surgeons are a very, very tough population to get on board with telemedicine. In COVID-19, during COVID-19, we have transformed almost 80% of our outpatient visits from in-person to telemedicine, at least in the first month and a half. And we noticed that the turn back into in-person visit from telemedicine visit was higher among surgeons, basically because they didn't feel comfortable. And we saw also an increase in imaging. So there was surgeons were ordering more imaging with the same population that they used to see before in person, probably because they didn't have enough reassurance that their patient is doing better. As for readmission rates, there we didn't see a huge difference, because in most cases where the surgeon was very concerned about these patients, they would resend them back to a walk-in visit, either at their clinic, or sometimes they just send them to the emergency department, go and take a look at them, make sure that they're doing well, and send them back home again.
Hi, Tim. How are you? Can you hear me?
Hey, Diana.
First of all, I just would like to tell the physician they're a great job. This really caught my interest with surgeons. And I think you're absolutely right. This was a study I'd like to have known about before, but when I was a telemedicine coordinator in an academic institute, I was very fortunate. I had 4 surgical services that did telemedicine with me. Now, ENT was one, colorectal, general, and urology. It is slow, it is tedious, but the takeaway, and I'd be really interested in, like you say, what are the gaps? I worked with all of those physicians and had known them from the past. So there was a trusting, relationship there. And if they ask a question, can I do this? Usually there was a patient that came into the clinic, and that was the driver that they knew were going to be difficult to either follow or assess. So I worked with all the services, and what the takeaway was, the surgeons realized that assessing the patient via telehealth was very lucrative. Number one, often they referred to the wrong service. Number two, they didn't have the imaging or the testing or what was really necessary for the surgeon to make a comprehensive decision. So they had time, and it wasn't a big cost factor, yet it was reimbursable. And patients would go locally and get all of those items that were requested. Then they would schedule to come in. They then finally figured out, oh, I don't get paid an extra fee for post-op. But surgeons, and I'm an old OR nurse, surgeons just don't want to let go. It's just something that has been part of their medical training since the beginning. And that was very difficult. So what we arranged was, if these patients had somewhere close to go, a clinic, a provider that had the capability, they could go locally for their post-op. And it took a while, but they were convinced in about a year that there's somebody there that's trained and skilled, and we would make sure we had camera capability and they could see it. If there was any question, they could always say, yes, you need to come on in, and arrange for them to quickly get back in. But if there was no problems, they could get their sutures taken out or the rest of their care done, and actually hand off to that primary care what needed to be done. Once they really embraced it, they never went back to doing it the other way. So you know, it
I
was,
think we've all experienced that, Diane.
Yeah.
I'm sorry, I'm going to have to cut you off. We have another
Go
post that
ahead.
we're going to have to do. So, like I said, if y'all want to meet up with the presenters, please feel free to after the presentations today to go to the main matrix page and look under attendees and meet up with the presenters. All right, now we have Ash, who's going to present on developing and testing novel visual fields. So Ash, if you want to go on and take it away.
Hey everyone, first of all, thanks so much for joining this session and listening. Thanks in advance for listening to my poster, and thanks Anita for accepting it and putting on this incredible conference virtually. And thanks Tim for moderating this session. So first, I am going to start out with a few background stats on stroke just to set the stage a little bit. There are 800,000 strokes annually in the United States and many, many more worldwide. Yet 45% of people in the US live greater than 1 hour from a primary stroke center. Stroke is a really urgent condition that needs rapid and really technical treatment. And on top of that, many non-specialists undertreat ischemic stroke, especially in the emergency department or other settings and in rural areas as well. So Telestroke came about 20, 25 years ago, and it solves many of these problems. Telestroke is a service where neurologists, trained vascular neurologists, provide remote medical care and for acute stroke patients to remote emergency departments. They provide timely care and they provide great assessments and then can recommend either treatment with TPA, which is a clot busting drug that breaks up the clot and is associated with much improved outcomes, and even help make the decision whether or not the patient's eligible for transfer to a primary stroke center for additional treatment. What we have found, and especially some of the neurologists at UVA who do a lot of telestroke, is that even though telestroke is an incredible service and it improves access and improves patient outcomes, it's still not the same as a true in-person stroke exam, especially with respect to the NIH stroke scale, which is how strokes are evaluated. It's a scale that scores patients from 0 to 34 on stroke deficits and really guides treatment decisions, and it can predict outcomes. One area in particular we found that telemedicine fails to meet standards for in-person is confrontational visual fields testing. So all of y'all here have been to the doctor where they've put a hand up over your eye and flash fingers in the different peripheral quadrants of your visual fields. It's relatively reliable and simple in person. However, via telemedicine, as you can see now, it's really, really difficult to assess because I can't actually put my fingers and flash my fingers in your peripheral visual field. And especially in the case of rural ERs and smaller ERs where they don't necessarily have the availability of trained providers to help out with this, often the test either takes a long, long time, which once again is terrible in a stroke setting, or the test isn't done at all due to urgency and time. Yet it's responsible for up to 3 points on the stroke scale, which can adversely affect treatment decisions. So we set out to make a device to facilitate these confrontational visual fields testing during the telestroke consult. We wanted the device to be simple. We wanted someone who has never seen it before to be able to pick it up and effectively use it. We want it to be robust. We don't want it to break. The last thing you need is a faulty device during one of these consults. It needs to be disposable so that emergency departments don't have to keep up with it. They don't have to clean it. They don't have to worry about where it is between patients. One size fits all so that no one has to measure the patient's face or try on multiple sizes of the device to actually have it work. And it needs to be versatile. Patients almost always present with multiple deficits. Some can be cognitive, some can be strength. And we wanted to make sure there are multiple ways that the patient can engage with the device and the exam so that one deficit wouldn't keep a patient from being able to actually use this test. So our solution for this is the Visual Fields Rapid Assessment Device, or the VRAD. It is, as you can see on the screen, it's made from a familiar glasses-like design. And all the parts on the device are really very similar to a pair of glasses or goggles that you would find at the store. There are LED lights in each of the 8 peripheral visual field quadrants, 4 per eye, and they are in the same locations that we would expect deficits consistent with a stroke. And you can see those down in the bottom left-hand corner of the screen there. The lights are controlled by a user interface. The neurologist will ultimately control these lights. They can be, a random algorithm can start that randomly illuminates all 8 lights twice in random order at random durations to make sure that the test can be used multiple times on the same patient without switching out devices or changing up the algorithm. And then also the neurologist is able to independently control each of the lights. So if there's one quadrant that needs to be retested or repeated, then the neurologist is easily able to do that. The neurologist interprets these results in real time. There's no reliance on AI or any software tracking eye movements to actually figure out if there's a deficit. And it also makes the results instantaneous from this test. And then finally, we're working on some additional capacity for the device and some additional features that we plan to build into the device. So we built the device and finally got it ready, and now we're working in the clinic to actually evaluate the device and see if it's effective. Right now, we have IRB approval and are underway with a clinical trial to assess human factors for the device. It's a small 20-patient trial where we're really trying to figure out how users, the telepresenter or the nurse at bedside, the patient, and the teleprovider or the teleneurologist are able to interact with this device and use it effectively in a simulated telestroke encounter. So with this, a provider is testing patients for visual field deficits using our device in a simulated telemedicine setting. These patients either come from the UVA inpatient stroke service or an outpatient clinic at UVA. And our primary outcome is to evaluate the usability of the device, with particularly with respect to comfort, ease of use, and safety. And then a secondary outcome, we hope to have a little bit of data about how well the device does compared to patient records and comparison to standard confrontational visual fields testing. After this trial, we will obviously correct any major device flaws, but preliminary data suggests that it's actually working really, really well in this setting. Ultimately, next we're working on designing an efficacy clinical trial to test whether this is non-inferior to in-person confrontational visual fields testing, which is really the standard of care for acute stroke consults. So for this, we are going to compare in 2 different assessments of the visual fields. One, an in-person confrontational visual fields test to a same-day confrontational visual fields test using our device. And then we will score, or the neurologist will score the deficits on the NIH stroke scale, and we will compare the 2 different, or both scores for each patient. And obviously the telepresenters and the teleneurologist will be blinded for that entire study. For the patients where we are able to evaluate additional, or able to compare to the gold standard ophthalmology evaluations, the Humphreys visual field analysis, we will definitely compare our scores with the visual fields device to the full visual field mapping and hopefully get a better idea on an absolute scale of how well our device performs compared to confrontational visual field testing and also attempted visual field testing virtually. So thank you to the entire project team. You can see the authors up above and Dr. Selinsky, who is here today. And I also want to thank the Ivy Biomedical Innovation Fund for funding for the past couple of years to develop this device. So with that, does anyone have any questions?
No questions today? I know on new medical devices here at the University of Louisville, we will work with the Speed Engineering School for the development of the actual product. Do y'all work within UVA to manufacture the glasses?
We haven't gotten to manufacturing yet. We've partnered with some UVA Masters in Engineering students to help out with the design of the interface and the hardware associated with the interface. And some of those students have helped out with the design of the glasses as well. But we're also partnering with an engineering firm in Richmond, Virginia called Spark Engineering, who's been incredible at helping us refine design and source some glasses for our trials.
Deb in chat said, what is the expected cost of the device?
It's tough to tell this early on. Based on the current prototype, I couldn't imagine the device would cost, at least the plastic portion of the device, so the actual glasses would cost more than at most $50 to make. And that's probably a really conservative estimate. It's all the components are really cheap when you start manufacturing them at scale using injection molding and other high volume manufacturing techniques. And then LEDs are literally a dime a dozen. So in terms of components, it's relatively cheap.
And she also asked, is it proprietary software or is it open source?
The glasses, we filed for a patent application for the glasses and some of the software. So I think we really filed for the method, both the physical glasses and also this method of confrontational visual fields testing.
Okay. Any other questions? We did get started a couple minutes late, so we can run over just a couple of minutes. If anybody has questions for any three of our presenters today. If not, I'll hand back that one last minute of time that we have here. Thank you all for presenting and everyone for attending. Also remember, do not forget to go to the main page of Matrix and vote for your People's Choice poster. Everything was excellent today. Thank you all very much.